All right, we'll go ahead and get started on ventricular dysrhythmias. And last week we talked about atrial dysrhythmias, so things that can go wrong starting in the atrium. And now we're going to the AV node and below and talking about arrhythmias that occur there. All right, so we'll start off with AV junctional dysrhythmias. And what I need you to write in your notes, something that you already know, but you can just write it again. If the SA node is suppressed, and fails to generate, electrical impulses, or if there is a block in conduction, the AV node will initiate impulses.
Can you say it one more time?
Mm-hmm. Pardon me. If the SA node is suppressed and fails to generate electrical impulses, or if there is a block in conduction, the AV node will initiate impulses. And then write down the most common causes of this occurring is hypoxia, ischemia, you could put cardiac ischemia, or MI, or digoxin toxicity. All right, so the distinguishing features are that the rate will be between 40 and 60 impulses per minute, so it'll be slow. It usually occurs when impulses from the SA node fail to reach the AV node. So the AV node will generate its own impulse. P waves are not seen. Sometimes they'll be inverted, and sometimes they can even occur after the QRS. All right, so looking at this, we see that there are inverted P waves. So when you see an inverted P wave, you know that the atria depolarized backwards. So the AV node initiated an impulse, and the atria depolarized, but they depolarized from the bottom to the top. So they depolarized in an opposite direction. And when you're looking at that on the EKG rhythm, it's upside down. And also, look at how close it is to the QRS. You know how we said that the PR interval is 3 to 5 boxes? Well, this is so close to the QRS. You can tell that it looks abnormal. Right, here's some examples. So at the top, you see a QRS, and the QRS is normal. So when you see a normal QRS, meaning 2 to 3 little boxes, you know that the impulse started with the AV node and then spread through the ventricles. If you see a real wide QRS, that did not start in the AV node. That started somewhere buried in the ventricle somewhere. You won't see a normal QRS if it doesn't start at the AV node. So this started at the AV node and it's normal, but there's just no P wave. So we would say it's a junctional rhythm. Also, if this is a 6-second strip, how fast is the rate?
50.
Yeah, 50 per minute. So it's slow. There's no P wave, but there's a normal QRS. So we know that it's a junctional rhythm. The strip below that, it shows an inverted P wave. QRS is normal. Again, we'll call that a junctional rhythm, and we just know that the atria depolarized backwards. Then the rate can speed up, so it can start with the AV node, but it can be faster. It's called accelerated junctional rhythm. The rate will be 60 to 100 per minute. And somehow this occurs because there's enhanced automaticity. Don't you love that? What's enhancing the AV node to start impulses faster than it's normal? I don't know. So you'll see a rate between 60 and 100. Again, your P waves will be inverted or you won't see them. All right, this is pointing to the P waves occurring after the QRS. And if it didn't point, I wouldn't be able to tell. What I notice is that there's no P wave, there's a normal QRS. But the rate is so fast, not so fast, but it's faster than the normal 40 to 60. 5, 6, 7, 8. So this shows a rate of 80 per minute. So how can that be that it's 80 per minute and it started with the AV node? The AV node can only initiate impulses 40 to 60 times a minute. So now when we say it has enhanced automaticity. Somebody showed me a strip like that this morning. There wasn't a whole lot to see. All we could see is the QRS, 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 no P wave. T wave wasn't showing up so well. It just looked like this. So that rhythm started with the AV node, and it's just a faster than normal rhythm, so accelerated junctional rhythm. And it can start going real fast if there's an irritable focus near the AV node. Like here it's saying the irritable focus is in the bundle of His. And it gives you a rate of 100 to 180 per minute. Again, your P waves will be inverted, and there will be a short PR interval. All right, so this is showing you a junctional tachycardia. The rate is faster than 100 per minute, but there's no P waves to be seen, but there's a normal looking QRS. So fast rate, no P waves. This one doesn't even have inverted P waves. But the QRS looks normal, so we come to the conclusion that it's a junctional tachycardia. So looking at this is 6 seconds. What is the rate? 170 per minute. So before today's lecture, what would you have called this?
No, I don't.
Sinus tachycardia goes up to 60?
So,
And you see a P wave?
Yeah, no. SVT.
Yeah, SVT. Very good. So how can you tell any difference between SVT and junctional tachycardia? I can't. I see a fast rate, 170 a minute, and I don't see any P waves. So if you continue to call this SVT, that's perfectly fine. But what if you're given a definition? The impulse is originated at the AV node or an ectopic focus near the AV node. You don't see P waves, and the rate is 180 per minute. Yeah, then you would call it a junctional tachycardia. Okay, now for arrhythmias or dysrhythmias that begin in the ventricles. The first one is called bundle branch block. There is an obstruction of the electrical impulse passing through the right bundle branch or the left bundle branch. The result is that one side of the heart will depolarize later than the other, and this will cause an abnormal QRS complex. So it looks like the letter M, doesn't it? And what's happening is conduction is going through one ventricle faster than the other. It's usually due to ischemic tissue. So a bundle branch block. And when you see a bundle branch block, you still have to mention what the underlying rhythm is. This is kind of strange, isn't it? You see your P wave, your QRS has the bundle branch block, and then your ST segment is below the baseline. So we have ST segment depression. But what is this lump in the ST depression? Is that the T wave down there?
And then there's a U wave.
And then you're calling this a U wave? Yeah, that could be. So we have a P wave, PR interval is normal, QRS is wide only because of the bundle branch block. So, and the rate is 80 per minute. So this would still be considered a sinus rhythm with a bundle branch block. Is this any easier to find everything? Okay, you obviously see the bundle branch block. Do you know why it's upside down? Instead of seeing an M, we're seeing a W? Yes, in a different lead, you see the QRS have a downward deflection. When it's depolarizing away from the positive electrode, it'll give it a downward deflection. But we see a P wave, QRS has a bundle branch block, and then we see the T wave. Does this P wave look inverted? It does to me.
Yeah.
And then QRST, normal P wave, QRST. So everything else looks normal. So you would say sinus rhythm with a bundle branch block. All right, then we talk about a premature ventricular complex. These are really easy to see on an EKG strip because it's a big, wide QRS. And it usually has a high deflection and it's wide, so it's really easy to spot it. It's a premature ectopic impulse that originates somewhere in one of the ventricles. The QRS complex will be wide. If it's from different ectopic sites, so if there's different irritable areas in the ventricle, all of the QRSs will look different from each other. Or the premature complexes will look different from each other. All right, and then it talks about bigeminy, trigeminy, and 3 in a row. Let's take a look. All right, so we've got a normal rhythm going along, and then all of a sudden we see this bizarre looking complex instead of our normal PVC. I didn't say that right. Instead of our normal QRS, this is a lot wider looking. So even if you don't count the little boxes, can you tell just by visualizing that this QRS looks abnormal?
Mm-hmm.
Okay. So that's called a PVC, or premature ventricular complex. When you have a PVC every other impulse, so a normal conduction and then a PVC, normal conduction, PVC. So when it's every other one, that's called bigeminy. So the ventricle is very irritable at this point, and medication is indicated to reduce that irregularity because it can quickly go into VTAC and VFib. Can you guess why this is called trigeminy?
Every third one?
Yeah, every third complex is a PVC. It doesn't show you 3 in a row. All right, is it coming up? No. Okay. So if you have 3 PVCs in a row, it's called a run of VTAC. 3 in a row is called a run of VTAC. Where is the 3 in a row is called a run of VTAC. And then VTAC is the lingo used to describe ventricular tachycardia, so let's talk about that next. I didn't give you the notes on PVCs. On PVCs, it's caused by an irritable ventricle, such as hypoxia, MI, low potassium, low K, or acidosis. And then write down there's no treatment if the patient is asymptomatic. If there are symptoms, the drug of choice is amiodarone. Do you know how to spell amiodarone? A-M-I-O-D-A-R-O-N-E, amiodarone. That'll stabilize the cells in the ventricle and make them less irritable.
Can you repeat the first part I have? PVC is caused by an irritable ventricle caused by hypoxia.
MI, low potassium, low K, acidosis.
Thank you.
Yeah, so if you have a patient on the ventilator and they're in ARDS and you're trying not to use more pressure to ventilate the lungs, you're trying to protect the lungs, so of course you'll use smaller tidal volumes, let the CO2 climb in the blood. And when you do, that's going to drop the pH. And one of the things you're looking out for is if the pH drops too low, you start getting arrhythmias, cardiac arrhythmias. So you'll start seeing more PVCs on the monitor. And it's because the pH is low, and that's what's causing the acidosis and the irritable heart muscle cells. All right, ventricular tachycardia has wide QRS complexes. The rate is 140 to 250 per minute, and you see no P waves. So big wide QRSs, if the rate is really fast, and it's just up and down, up and down, up and down, up and down. All right, how do you treat this arrhythmia? First, I need you to write down that this is a lethal arrhythmia. Lethal arrhythmia. Patient can go into a full code from VTAC. So it's very serious, and it needs to be treated right away. So if the patient goes into VTAC, you'll see it on the monitor, and sometimes they'll be awake, and they'll still have a pulse with it and a blood pressure, and you see it on the monitor. So you get the crash cart in the room, and you get ready to defibrillate, but you might have a little window of time before the heart deteriorates anymore to get some amiodarone into the IV. And once you stabilize the heart muscle, then it'll go back into a normal rhythm. So it says with a pulse, give amiodarone 150 milligrams IV over 10 minutes. The dosage is not necessary for you to memorize for your exam in 2 weeks. When you're taking your ACLS course, they expect you to memorize the dosages. But, for this class, you don't have to. All right, so how does amiodarone work? It affects the sodium, potassium, and calcium channels. It also has alpha and beta adrenergic blocking properties. So it's going to bring down blood pressure as well as stabilize the cells so they can't be so irritable. All right, so the amiodarone is given and still the patient is in VTAC. They still have a pulse. They're still neurologically with it. The next thing you would do is synchronized cardioversion. So the leads are put on the chest, and of course we have to synchronize and deliver the shock during QRS so we don't go into VFib. When you're cardioverting, do you remember the amount of energy that is used?
50 to 100.
Yeah, 50 to 100 joules. All right, so you're in the patient's room, you see VTAC on the monitor, you see the eyes roll back in their head, and they're unresponsive, and then they start turning blue. What happened is they went into VTAC, but there's no cardiac output with that rhythm. So they're getting no blood flow to their vital organs, and now they're considered a full code. So you check for a pulse because there's a lot of things that can happen when you see VTAC on the monitor or even VFib on the monitor. Like when you're doing CPT on a patient, you'll see the monitor techs run into the room. So you always want to tell the monitor techs first before you're doing CPT on a patient on a monitored floor. Because as you start doing CPT, it makes these big complexes show up on the EKG tracing, and it looks like the patient's in VTAC or in VFib, two very lethal arrhythmias. So you let the monitor tech know ahead of time. So always check a pulse first, because sometimes a lead can come on, or when the patient's moving, it can cause weird arrhythmias. So it's a test question, it's an ACLS question, it's bedside safety question. What's the first thing you do when you see VTAC on the monitor? Check a pulse. Always. First thing you do, check a pulse. And then if there's no pulse, then you begin CPR. Now when you're checking for a pulse, do you know where to find the carotid artery? Do you just head to the side of the neck? How were you taught during your BLS class to find the carotid artery? There was no mention of it? All right, so it runs near the trachea. So best thing to do is put your fingers on the trachea and then slide over whatever side you're facing. And that's where you'll feel the carotid artery the strongest. You want to take about 5 seconds because sometimes you can just miss it. It's there and you miss it. So middle of trachea, go over to the side that you're on, and then you'll feel it. You only feel it on one side? Were you up too high at first? You have to come down? Go to the middle? Yeah, up by the jawline, it starts going more internal. It's not as close to the surface, but near the trachea, like middle of trachea, whatever side you're standing on. You should feel it. Everybody's got a carotid pulse? I don't think Ledger has one today.
I already did.
All right, so if there's no pulse, then you start compressions. And it's really important to defibrillate as fast as possible. So the sooner that the pads are placed on the chest and defibrillation is given, the better the chances of the heart going back into a normal rhythm. the more minutes that pass, the less the chances of being able to defibrillate back into a normal rhythm. So there's different types of defibrillators. The older ones are called monophasic defibrillators. And what that means is when the energy is discharged from one of the paddles, it only is discharged from one of the paddles, and it'll travel through tissue, bone, and depolarize or deliver a lot of energy to the entire heart. And it causes all of the muscle cells to depolarize. Biphasic, you've got energy leaving both paddles and traveling through to the opposite paddle. So biphasic, both paddles send energy to the chest. So when you have both paddles sending energy through the chest, you need less joules or less energy. So ask, like you're going to defibrillate later, and one thing you want to know about the monitor is whether it's monophasic or biphasic. So you have to ask, is this monophasic or biphasic? All right, it's monophasic. And then you have to verbalize, okay, we would use 360 joules of energy. And then you show proper placement, how to clear the bed, and how to deliver the shock. If you're told that the defibrillator is biphasic, then you would say, okay, we'll charge up to 200 joules and then deliver the shock. There's a type of VTAC, and it's called, and I don't have a very good accent to say this, Torsad.
Torsad is the point.
All right, Alyssa. How do you say it? Torsad?
Susie, would you like to tell?
Torsades?
Susie? Demonstrate. Wrong Spanish person. Caroline? Caroline? Where's the
Caroline?
It's not Spanish though. Sounds like it is. French. That's French.
It's French? How do we do? Torsades? No.
De Puentes? I don't know. I thought it was
De
Spanish.
Puentes?
Mother speaks French.
Oh.
It's not Spanish.
Come on, Montreal.
Who's from Montreal?
Logi's from Montreal?
Yeah.
Oh, no kidding.
But he said it sounds Spanish. And it's French.
It's French. It's all a blur. It's all of us.
What do you guys
All right, so what it looks like is there's twisting of the points where you see some of the complexes going up and then some go down. Some go up and then some go down. So it looks like a twisting, you're twisting on an axis, twisting of the points. The treatment for this is magnesium sulfate. So the body is really low on magnesium. So if you were to draw a blood level, you would notice that the magnesium level in the blood is very, very low, and that's what's causing this arrhythmia. So the treatment is magnesium sulfate. Okay, now we'll talk about ventricular fibrillation. And ventricular fibrillation is when the ventricles fibrillate or quiver instead of contracting normally. So the ventricles will fibrillate or quiver instead of contracting normally. And when you see that on the EKG monitor, it's a coarse, wavy line. So that coarse, wavy line is the same way it looks as if there's a loose lead. So again, make sure you check the patient's pulse. When the patient is in VFib, there is no pulse. If the EKG lead is disconnected or loose, it may also cause the same look. So you check a pulse, you feel no pulse, you start compressions, and here's your coarse wavy line. The longer that the heart is in ventricular fibrillation, the finer the line becomes. So it starts off really coarse and chaotic, and then after a couple minutes, it starts becoming really small coarse lines, and then eventually asystole. And this is showing you a picture of all these irritable spots, and they're just quivering. There's no normal conduction going on.
So ventricular fibrillation will lead to
Yes. Ventricular fibrillation will lead to asystole. All right, so you notice that VTAC without a pulse and ventricular fibrillation, or VFib, has the same treatment. VTAC without a pulse, VFib, same treatment. You've got no pulse, you start CPR, and you want to get the defibrillator there as quickly as possible. You administer epinephrine, 1 milligram every 3 minutes to 5 minutes. Do you know why you have to give it so often?
It's a
It's a very short.
It's a very short half-life or duration of action. So you're giving CPR, you've defibrillated, the rhythm did not change back into a sinus rhythm, so you give epinephrine and you do 2 minutes of CPR. If there's still no change in the rhythm, then you'll shock again. So you repeat your defibrillation again. Then, if there's no response, you would recommend giving 300 milligrams of amiodarone. Again, you don't have to memorize the dosage of amiodarone. You just have to mention that it should be given. So it goes shock, drug, shock, drug, if that helps you to remember as you're going through the code. Start CPR, shock as quickly as possible, 2 minutes of CPR if it hasn't converted the rhythm. Now you want to give epinephrine, shock again. If it still doesn't convert, then you give amiodarone. All right, what are different ways that epinephrine can be given? Okay, so IV. Can it be given intraosseous into the bone? Isn't that disgusting? But it's true. Yeah, and everybody talks about it like, oh, just give it intraosseous. Stick it in the bone? Are you crazy? Do you know how painful it is? Even when you're unresponsive, it's got to be painful. All right, so IV, intraosseous, and then down the endotube. Now, if you place epinephrine down the endotube, and 1 milligram is the normal dosage, is that how much you put down the endotube?
No, you
Yeah,
gotta
plus.
You double the dosage, so it'd be 2 milligrams of epinephrine down the endotube.
Saline?
Follow it with saline?
Do
No.
you just put the epi and let it go?
Yes.
Is intraosseous 1 milligram as well?
Yes.
So it's 1 milligram, but you're pushing to.
Yes. 2 milligrams down the endotube.